Hello and welcome to this discussion on the respiratory system. The respiratory system will be one of the systems included on the final exam. Uh, the respiratory system, along with the urinary system and the reproductive systems, will be the primary content on that fifth and final course exam. We're only going to be taking a look at BLOSSOM 22.1 and 22.2. So let's get started on this fascinating system. You'll also be learning a lot about this system in lab this semester. So let's take a look. So we all breathe. We get the idea. We realize that the words inspire and expire have a couple different meanings, don't they? To inspire is to be excited, right? To be motivated, to be in awe of something. Wow, and here we are inspiring air. And that certainly does bring life and vitality to our bodies. And to expire is to breathe out, but also to expire is to die. So we realize quickly that breathing is absolutely necessary for life, right? And that without oxygen, life is not possible. The lungs and the respiratory system are the very way by which our body receives oxygen. That oxygen is going to be picked up in the lungs, down in the microscopic alveoli by capillaries that are going to grab that oxygen, and it's going to take a ride on the hemoglobin molecules that you learned about back in the cardiovascular system. So if you're looking for a connection, there is not a more obvious one right there than the oxygen taken in by the respiratory system, picked up by the hemoglobin in the capillaries of the lung. And that is also in the capillaries of the lung where the body returns CO2, carbon dioxide waste products from cellular respiration. So remember that every breath we take in is mixing with the food and the glucose of our diet, and together that oxygen and glucose is necessary for nourishing our bodies. But from those ingredients, we use that energy, but we create waste products. And those waste products, one of them is CO2. Now, some of the other waste products that are created are released through the blood, through the kidneys. And you'll be hearing about the urinary system and how those waste products are removed from your blood via the urinary system. So let's just take a look at the main anatomy of the respiratory system. And in this unit, you're going to be looking at basically three different models, three different sets of images. It's one large image, but you're going to be taking a closer look at the oral region and the nasal region. And so we recognize that as we go up into the nose, right, into the nasal passages, we're going to see some conchae in there. Those concha are basically shelf-like dividers that are going to create tube-like passageways through which the air is going to pass. The air is going to travel to the back of the nasal cavity, back into the nasopharynx, and then down past through the oropharynx, and then laryngopharynx. The air is then going to continue down past the epiglottis, down the glottis and the larynx. And again, everything I'm saying extra we'll see here in a minute. And down the trachea. The trachea is going to bifurcate, divide at the carina, and it's going to split into the right and left primary bronchi, or each one is a bronchus. As the respiratory tube continues, it's going to branch into smaller and smaller branches. Those smaller and smaller branches are the bronchioles. And the bronchioles are eventually going to get down into microscopic grape-like clusters, air sacs called alveoli. Each one is an alveolus. We have a right and a left lung, and as you'll see, there is a significant difference in the two. The left lung, because it has to make room for the heart, is significantly smaller and only contains two main lobes, whereas the right lung, not having to make room for the heart, is larger and receives more air with every breath and is divided into three separate lobes. The diaphragm is the major muscle of respiration. The diaphragm is a skeletal muscle, a voluntary muscle, and it is the divider also between the thoracic cavity and the abdominal pelvic cavity. So let's take a closer look at the respiratory system. And first, let's divide the respiratory system up into two main areas. First, it's the conducting zone. Think of the conducting zone basically as a straw, right? It's simply the pathway that air passes into and down into where gas exchange happens. In the conducting zone, there is no gas exchange. So the conducting zone, no gas exchange, okay? It's basically the straw that allows air to get into the microscopic structures, and then the gas exchange is going to occur in the region referred to as the respiratory zone. So we just took a picture here. As air comes in through the nose, travels down the pharynx, and we know that air can also come in through the oral cavity. So all of this air comes in, goes down the trachea, goes down the bronchi and the bronchioles. All of that is the conducting zone. Along that pathway, there is no gas exchange occurring. It's only till you get to the microscopic little air sacs called the alveoli where the gas exchange occurs and the oxygen hitches a ride on the hemoglobin in the blood capillaries. So the conducting zone, again, it's everything that's gross. By gross, I mean large, that you can see with the naked eye. And even some of the microscopic structures are also considered part of the conducting zone. So what else is the conducting zone besides just the pathway for the air? Well, as air comes into your lungs, the air is going to be warmed up a little bit, okay? And it's going to be humidified a little bit. Now, if you're outside in the winter time in Michigan, then clearly that cold air is going to get warmed up as it comes in. We're not oftentimes in an environment that is warmer than our body temperature of 98.6, but when we are, you could even imagine that the air is almost cooled off a little bit as it comes into our body. Also, we know that in our nasal passages, we have nerve endings for the olfactory nerve, cranial nerve number 1. So we know that with breathing also comes the sense of smell. And also along the nasal passages and down the trachea, you are well aware that there is pseudostratified columnar epithelium, and that pseudostratified columnar epithelium contains goblet cells and cilia, and those cilia are important in cleaning out and sort of sweeping particulates and pathogens out of the air. So there are many, many things going on in addition to even cleaning out possible carcinogens, which can come in through our air. So let's take a look more at the nose. I'm not going to worry about a couple of things here. So the dorsum nasi, the apex, I'm not going to worry about those terms, okay? So let's not worry about those. Let's put those in blue. And I'm not going to worry about the ala either, okay? Not going to worry about the ala. But I do definitely want you to know the nares. And the nares are simply the nostril openings going up into the nasal passages. Some books might even refer to that as the nasal vestibule as you enter into the nose itself. We are aware of the nasal bones that are creating the structure, which you might refer to as the bridge of your nose. And there is the little philtrum. The philtrum is that little divot, right, that we have above our upper lip that sort of heads up toward the nose and is contiguous with the apex. The apex is the little part that comes down. You know the term apex, for example, from the heart. So that pointed conical end. The nose is made up of cartilage, and that cartilage, keep in mind, is not bony. So For your nose, the nasal bones, of course, are good old skeletal bone, compact bone, but the majority of your nose is made up of cartilage. Definitely watch these videos. You know about the nasal septum. It is what divides the left and right sides of your nose. And you know that there's two parts to the nasal septum. We learned this in the skeletal system. There's the perpendicular plate of the ethmoid bone. That's the more superior portion of the septum. And it meets up with the vomer, which is on the inferior portion of that septum. And then when you go into each nostril up in the nasal passages, we see three concha. There's the superior, the middle, and the inferior concha. Now, the inferior concha, remember, those are separate bones. Back when we were learning the skeletal system, we named two little bones on the inside of the nose, the inferior ones, as separate bones, and that is true. The superior and the middle concha are actually bone markings, portions of the ethmoid bone. Okay, so keep that in mind, that what we're looking at here, most of this, right, you've got the perpendicular plate and the superior middle concha are all parts, bone markings, labeled regions of the ethmoid bone. Now, the concha, as we see, are creating these spaces through which air passes, and the passageway through which air passes is referred to as the meatus. Recall back in the skeletal system, we had the external auditory meatus. That was the opening through which sound waves pass through the temporal bone into the ear. And likewise, a meatus is a tube-like passageway. The floor of the nasal cavity is composed of the palate. You have the hard palate, the bony portion, as well as the soft palate toward the posterior portion. And we can refer to the palate both in the nasal passages, but you can also think of the palate in the oral passages, in the oral cavity. So again, the hard palate is made up of the palatine bones, okay, and the soft palate is not bony, but is soft tissue. There are some things on here that you already know well. Let's just take a look at them, and maybe a couple of things that are new as well. So again, the external nares are the flaring part of your nostril. The vestibule would be the entryway in. And here we see these three concha. The superior and the middle concha are just extensions of, or swellings of, the ethmoid bone. The inferior nasal concha, the bones underneath this mucosa, are separate pair of bones, left and right side. As air comes up into the nasal passages, it's going to pass through these tubes, these meatuses. So we have a inferior, middle, and superior meatus. And air, as it comes in, is sort of being sent through a tube, and it kind of swirls. And this increases the surface area, assuring that that air gets humidified and warmed. Also, remember that everything I'm pointing to is coated with that pseudostratified columnar epithelium with cilia. So we have a lot of mucus being produced up in here, and we also have the cilia. Now here, not labeled, but remember that the olfactory nerve, cranial nerve number 1, comes right across the bottom of the frontal lobe, and there are little openings, remember, in the ethmoid bone referred to as the cribriform plate. And those little openings, right, are allowing for the olfactory nerve endings to come down and permeate into the mucosa of the nasal passages, allowing for the sense of smell. Also here in the nasal cavity, back here in the nasal pharynx, there's the entrance to the auditory tube. Remember, the auditory tube has two other names. It's also called the pharyngeotympanic tube. It's also called the eustachian tube, and that is the tube that goes up into the middle ear. Not shown in this particular picture, but right here where my pointer is, you would have the adenoid, and the adenoid is one of the tonsils. The adenoid is a lymphatic structure, and like the palatine and lingual tonsils are full of lymphocytes and are looking for invading bacteria and viral things to which it can set up an immune response. So you learned about those tonsils a little bit back in the lymphatic unit. Recall that tonsils have an incomplete capsule around them so that particulates like allergens and bacteria and viruses are able to penetrate into that tonsil, where they can come in contact with white blood cells that can set up an immune response. Also, don't forget that right here we have the sphenoidal sinus and the frontal sinus. Those are the only two sinuses that are visible in a mid-sagittal cut through the head like this. There are also ethmoid sinuses, and there's also maxillary sinuses that we'll see in a different angle, but never can you see those in a mid-sagittal slice like this. Also over here, just a reminder back to our skeletal system, this is the sphenoid sinus because it's in the sphenoidal bone. Remember, the sphenoid bone also had the sella turcica. So there we can see the sella turcica, and you can see the artist has included the pituitary gland in that space as a reference point. So the most superior part of the pharynx is the nasopharynx. The nasopharynx basically travels down as low as where the uvula drops down. So the uvula, if you open your mouth and say ah, you see the soft palate hanging down in the back. That most extending portion is called the uvula. And so the nasopharynx, by definition, goes as far as the tip of the uvula. When you move beyond that point, you're now in the oropharynx. Now, the oropharynx has the same epithelium as the oral cavity. So don't forget that here you have stratified squamous non-keratinized. If, and I don't have a picture of this, but if you were to zoom in to the mucosa here, and you looked at the nasopharynx, you would see pseudostratified columnar. And then if you look just a cell below that, in the oropharynx, you would see a dramatic change in the histology as it switches over to stratified squamous non-keratinized. It's a pretty dramatic switch right here. So the oropharynx is the midsection of the pharynx, and it pretty much goes from the tip of the uvula down to the epiglottis. The epiglottis is a cartilaginous structure with some elastin in it. It is going to, as you swallow, kind of move down and block food from going down into the trachea. But when you're breathing, the epiglottis is going to stay just like this. The esophagus here is a relatively narrow tube, and if you were to travel to the bottom of the esophagus, you would see that there's the cardiac sphincter there. Recall that from the digestive unit. So this is really not a passageway for air. And so air goes to the place of least resistance, and air now will travel into the larynx region, the laryngeal region, and where this is the epiglottis, this flap, the opening into the trachea is called the glottis. Okay, the glottis. And so the glottis is just the opening into and what is right below the epiglottis. And then as you pass by the glottis, you see the vocal folds, and we'll take a closer look at those as well. Before we got to the trachea, we also went through the third and most inferior portion of the pharynx, the laryngopharynx, on the way into the trachea. And everywhere where food would go, again back to histology, everywhere where food would be, tongue and in the oral cavity and in the oropharynx and down the laryngopharynx and down the esophagus, you know that there's stratified squamous non-keratinized. Once you get into the trachea, once again, it is lined by pseudostratified columnar epithelium with cilia. So that's a quick review or maybe introduction to all that we're seeing here in this mid-sagittal cut of the upper region. This video, definitely make sure you watch it, is highlighting the paranasal sinuses. I just showed you two of those sinuses here. In a mid-sagittal cut, we can see the sphenoid and the frontal sinus. But as you know, there are two frontal sinuses, both in the frontal bone. There is the sphenoidal sinuses, which are deep in here. There are the ethmoid sinuses, which are closer to the lateral sides, which is why you don't see them. And then these big green guys are the maxillary sinuses. And again, if you slice right through the mid-sagittal region, you'll probably get a little bit of the frontal and a little bit of the sphenoidal sinus, but you won't see ethmoidal or maxillary sinuses. Paranasal sinus just means next to the sinuses, or next to the nasal regions, I should say. And again, there are 4 types of nasal sinuses. Make sure you can label those 4. They are producing mucus. They're lightening the weight of the skull. They're also creating resonance for your voice. So we've all heard of someone with that, quote, radio voice, right? Who has that booming radio voice. Well, part of their quality of their voice is just from the echoing, the acoustics that are caused by their sinuses. And we all know that when you have a cold and those sinuses are infected or filled with mucus or infection, that your voice sounds different. Not only do people sound different, but you sound different to yourself as well. Your hearing is somewhat affected by fluid buildup in those sinuses. So we refer to, we know about pseudostratified ciliated columnar epithelium. The other name for that is, that you will see often, is respiratory epithelium. And so pseudostratified columnar is also called respiratory epithelium. And it just reminds you that this is the kind of epithelium you find where essentially only air is found. So you find this pseudostratified columnar epithelium in the nasal pharynx, lining those concha, lining those meatuses, even up in the sinuses, plus, of course, the trachea. This is a great video that reminds us why you need those cilia along the respiratory mucosa and the significance of it in removing debris that comes in with the air that you breathe. Those cilia are beating constantly in a unified, coordinated way, and that is upward. So the cilia are encouraging things to be moved upward. That's called the mucus elevator. And as a result, you are constantly sort of swallowing some of that gunk that has gotten attached to that mucus and has come up that mucus escalator or elevator. So we can see the evidence of that here, right? Those particulates and the mucus are being pushed upward, and then you basically are constantly receiving that fluid and swallowing it. We know exactly what pseudostratified epithelium looks like. Let's zoom in. So if we take a look at this, we see the basement membrane right here all along. Everything below the basement membrane down in here would be connective tissue. And then we see that characteristic pseudostratified columnar epithelium on the surface. Even at this magnification, you can see that we can see these individual cilia. And then here is the lumen of the trachea itself. Goblet cell, labeled and shown here as well. There's a goblet cell. I can see one right here, right? These kind of billowing white cells. You can kind of see them mixed in here. And those are the mucus producing cells. So let's continue our journey, and we've come in through the nasal passages. We talked about those structures. Now we are in the pharynx. You know that a pharynx is a tube-like passageway and made up into 3 parts: the naso, oro, and laryngopharyngeal regions. Let's take a look at that, again, in this particular rendition, actually includes a couple of things that I alluded to, but were not included on the previous picture. In this particular drawing, the meatuses and the concha are not shown. It labels all of this space as the nasal cavity, but you know that that's simplified. That is not an accurate rendition, right? Because it's lacking the meatuses and the concha. Here, though, we do see the adenoid. And the other name for the adenoid is the pharyngeal tonsil. Again, that's a lymphatic organ, and that's a great connection. This region is the nasal pharynx. We have the hard palate and the soft palate. The uvula is hanging here. Now, this is the mid-sagittal cut, and so this is a palatine tonsil. It's not, it's a little bit misguided in that the palatine tonsils are going to be lateral to either side of the uvula. That is not obvious here, but you have a left and a right palatine tonsil. When someone is having their tonsils removed, it is most often a palatine tonsil. The palatine tonsils, when they get infected or when there's chronic infections, especially in a young person, they can become very enlarged, and that can actually make swallowing difficult, feeding difficult for a young child. It can also lead to a lot of infections. If the palatine tonsils get infected, oftentimes the adenoid also gets infected, and the adenoid is sitting right next to this opening, although it's not that obvious here. Remember, right about here is the opening up to the middle ear. So if you have chronic infections, oftentimes that infection can travel up that eustachian tube and cause a middle ear infection called otitis media, and that's a very painful ear infection. And if that infection becomes too significant, it can actually damage, rupture the tympanic membrane, and can actually lead to hearing loss. So if a child has recurring infections and the adenoids are affected and the middle ear is getting recurring infections, oftentimes they'll put tubes in the ear, and that those tubes, they'll remove the adenoids altogether, and they'll put tubes in the ear to relieve that pressure to minimize the possibility of rupturing the tympanic membrane. Again, here's the uvula. Those are the palatine tonsils. We're now behind the oral cavity, so there's the oropharynx. And then there's a couple of other tonsils called the lingual tonsils, and one on either side, basically on the tongue. Right here's the tongue. So the lingual tonsils, much smaller, and they're on either side of the epiglottis. Here's the epiglottis, not labeled in this particular view, and here is the laryngopharynx down here, which is basically where there is the separation or the division into the esophagus and down into the trachea. The opening into the trachea is the glottis, and then here we have the vocal folds. We'll take a look at that in a moment. Little video here about the tonsils. Again, the pharyngeal tonsils are also called the adenoid. It's a single large structure. And again, like all tonsils, it is part of your lymphatic system and is screening for potential incoming critters. And here is what I just talked about with the eustachian tube. Oropharynx is the passageway for both air and food. There's a connection, therefore, between the digestive system and the respiratory system. And again, nasopharynx has the pseudostratified, whereas the oropharynx has the stratified squamous non-keratinized. Here's a view of those palatine tonsils when they are not infected, and they can become much, much larger and quite large during an active infection. So another model, another image, another perspective you're going to be seeing is what I call the trachea on the stick, or the larynx model, as is shown here. And the larynx is a cartilaginous structure. There's a number of pieces of cartilage that make up the larynx. It is basically a protective box around your, quote, voice box. And we always see included here this hump this cartilaginous structure here is the epiglottis. You saw the epiglottis also in your fetal pig dissection. If you opened up the mouth very, very big, looked down into the pharynx, you could see this little flap sticking up. Here's the hyoid bone. Man, we don't see that very often. Remember, the hyoid bone is the floating bone. It's a single bone. It's the only bone that is not directly articulating with another bone in the body. And then the other significant pieces of cartilage, we'll see this in another picture in a moment, but the biggest piece of cartilage is the thyroid cartilage. Then this big piece of cartilage is the cricoid cartilage, not coracoid, not coronoid, but cricoid. And then below that, we have the trachea with the C rings, the tracheal rings. So again, let's take a look at those structures. The ones that I want you to know, the thyroid cartilage is the big dude. And then the second largest is the cricoid cartilage. Associated with the thyroid cartilage is a bump called the laryngeal prominence. You know this better as the Adam's apple, and that is something that is more commonly seen in men as a secondary characteristic about puberty. That laryngeal prominence can become more prevalent. Some men don't have any obvious Adam's apple at all, but some do. There's a number of other pieces of cartilage and a number of other ligaments that hold all of this together. You'll review those in the lab, but I'll tell you now, the big ones are the ones that are in bold here: epiglottis, thyroid cartilage, laryngeal prominence, cricoid cartilage. As we take a look at a lateral view of the larynx, here's that epiglottis. Here would be the glottis, basically the entryway into the trachea, and we're going to see that there are two ligamental structures. The more superior ligamental structure, zoom in here, the more superior ligamental structure is called the vestibular fold. There's that word again, vestibular. Vestibular meaning entryway into, or as you enter into the vocal cord region, there's the vestibular fold. This is not a vocal cord. It is sometimes also referred to as the false vocal cord. Just inferior to that are the true vocal cords, or the vocal folds. These are the ligamental structures through which air passes. These vocal folds have ligamental structures within them that vibrate, and this is the source of the sound waves that are associated with your voice. Again, the big piece of cartilage is the thyroid cartilage. The second largest piece is the cricoid cartilage. And then below that, there's a variable number of tracheal cartilages. Now, these tracheal cartilages are not completely circular. They don't go all the way around the trachea. In fact, they're shaped like C rings or like horseshoes, and you'll sometimes see them called C rings. And they are cartilaginous rings that go around the trachea. On the back side is the esophagus and a muscle that separates the trachea, and we'll see that in a moment. That's the trachealis muscle. So you can read what I just described here: the epiglottis, the glottis, the vestibular fold, the true vocal cord. In the lab folder, there is a really cool video. It shows 4 people singing while they have a camera inserted down their nasal passages, down their nasal pharynx, down their oro and laryngopharynx, and hovering right over their vocal cords. And in that video, what you see looks like this. You see this V. Well, that V is truly the vocal cords. Now here, the vocal cords are separated. You see the V, right? The V. If you see the V, the cords are separated. This person is breathing. Air is passing back and forth. There is no vocalization occurring. When you are speaking, these two vocal cords come together. Air passes by them and causes these vocal cords to vibrate, producing sound. Now, if you are a male and you have a low voice, right, a bass, these are going to be thicker, bigger vocal cords. Tenors, guys with higher voices, are going to have thinner cords, and then women are going to have even thinner cords, shorter and thinner. Look at a piano, and the top keys have shorter, thinner strings. The bass strings are thicker. Okay, on a guitar or on a bass, you see the same thing. You see different strings, the thickness of the string. On the guitar, they're the same length, but they're much different in thickness. And again, the thinner strings are the higher pitched strings, and the thicker strings are the lower pitched strings. Once we get past the vocal cords, we're now down in the trachea. Again, the trachea is going to have those 16 to 20 or so C-shaped pieces of cartilage. This is good old hyaline cartilage, the most abundant type of cartilage. If you were to see cartilage under the microscope, you know exactly what you're looking at when you see hyaline cartilage. On the back side of the tracheal C-rings, there's that trachealis muscle, and that is going to allow the trachea to stretch as you are eating. So here's the larynx, the voice box, and then the trachea with those tracheal cartilages. And then as air is coming down the trachea, we get to the bifurcation. The bifurcation of the trachea is called the carina. You'll see that word come up in a moment. And it splits into the left and right primary bronchi. These are also referred to as the main bronchi. And even in this rendition, you can see that the right primary bronchus is bigger in diameter than the left. And the reason is more air travels to the right lung. It is composed of 3 lobes. And on the left side, because it has to make room for the heart, the left lung is only composed of 2 lobes and only has a thinner left primary bronchus. Once you go into the lung, the primary bronchus then splits into secondary bronchi. Now, I'll tell you this now, it's difficult sometimes to label this, and this is as far as we will label, but there are officially as many secondary bronchi as there are lobes. Therefore, the left side is going to have 3 distinctive secondary bronchi. The left side will only have 2 secondary bronchi, and sometimes these secondary bronchi are called lobar bronchi because there's one for each lobe. And that's all described here for you. Okay, a bronchus again splits at the carina. There's that word. The carina is simply the place where it splits, and I always remember that. My sister-in-law's name was Karina, and in my opinion, she had a split personality, so I have no hard time remembering the word carina or Karina. It's pronounced carina because of her, quote, split personality. Remember that all the way down the trachea and into the bronchi, we still have the same pseudostratified ciliated columnar epithelium. At the carina, there's actually a little bit of nervous tissue there that can induce coughing. So if there is a foreign body, something that you eat by mistake that makes it down the trachea, it actually can create a spasm, if you will, to help get that out of and not block the airway. The primary bronchi enter into the lungs at the hilum. I'll show you the hilum in a moment. I can go up to here and show you the hilum. But the hilum is basically where I'm highlighting now. The hilum is simply the indented region where everything enters into and out of the lungs themselves. So coming into the hilum associated with the bronchi, there are lots of airways. We're going to see, well, you know, from the heart, the pulmonary arteries and the pulmonary veins are going to be leaving also at the hilum. There are also significant lymphatic structures that are associated with the lungs as well. So from that trachea into the primary bronchi, into the secondary bronchi. There are many, many layers of division. This is referred to as the respiratory tree. Almost picture it like an upside down tree, right? You know that a tree has the trunk. Think of that as like the trachea, and then the major branches like the primary, and then the secondary branches off from that, and then we keep dividing and dividing and dividing. And there's somewhere around 20 to 25 layers of branching as the bronchial tree expands. Most of this is still part of the conducting zone. Now, as you get further and further down into the microscopic structures of the bronchial tree, you move into bronchioles. Bronchioles are branches from the tertiary bronchi. Now, what's the difference between a bronchiole and a bronchus? Let me highlight that again. So bronchiole versus a bronchus or bronchi is simply plural. The difference is this: whenever there is a bronchus, I don't care if it's a primary bronchus, secondary bronchus, tertiary bronchus, if it is a bronchus, there is still cartilage surrounding at least part of that airway. Okay? When you get to a bronchiole, a small bronchus, bronchiole, by definition, a bronchiole no longer has any cartilage surrounding it. Okay, and you have more than 1,000. These little bronchioles keep going down and eventually get into the terminal bronchioles, and the bronchioles are then leading to the respiratory zone. So everything above this place has been conducting zone, right? It has simply been the passageway through which air passes down to the respiratory zone. Once you're in this microscopic respiratory zone, now we're talking about the places where gas exchange occurs. Where this begins is going to be a respiratory bronchiole. It tells you it's respiratory. So let's take a look at this picture. Let's take a moment to really understand what we're looking at. I'm going to actually go back up, make sure we're good with this. You are looking at, if I could zoom in right here, right here, and look at the end of this little bronchus or bronchiole. You even see in this picture, right? You can see where you see the cartilage, 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 and then you see how some of these branches don't have any of this cartilage around it. Can you see that here in the diagram? So once you're down in here, what the artist is trying to show you is that these smooth tubes are bronchioles because there's no hyaline cartilage associated with them. So we're going to go down into one of these little dead end regions and pick up that story right here. So you're now coming down a terminal bronchiole. All that means at the end, right? Terminus, terminal. If Aunt Susan has terminal cancer, right, she has a cancer that's likely going to end her life. That's the way I think about it. So terminal is at the end, and the terminal bronchiole is still part of the conducting zone. There are bands of smooth muscle around the terminal bronchiole. Notice there is no cartilage. I'm drawing a line right here. Everything above this line is conducting zone. Everything below this line is basically respiratory zone. And what you see down here is that you begin to see these little grape-like pouches coming off from the bronchiole. So down here, this is a respiratory bronchiole. How do I know it? Because I can see alveoli bulging off from it. There's gas exchange happening here. So this is a respiratory bronchiole, and the respiratory bronchiole leads into a cluster, a grape-like cluster of air sacs. Each air sac is an alveolus. The collection of these grapes is called a alveolar sac, and each of these alveoli has a pathway into it through an alveolar duct. Now, here's what's so cool. Every one of these alveoli has its own capillary bed surrounding it. Now remember, we are in the lungs. That means that blue blood, deoxygenated blood, is coming down a branch of the pulmonary artery. So this would be more officially called a pulmonary arteriole. And these pulmonary arterioles would lead into capillary beds, bringing that CO2 and that deoxygenated blood to the airway. Air is coming down into the alveolus. That oxygen is going to be picked up by the hemoglobin in the blood capillaries. And you know that at that point, the hemoglobin is going to be a bright red. So then this freshly oxygenated blood is going to leave through a small pulmonary venule and pass back to the pulmonary veins. So remember, when you're looking at anything in the lung, blue vessels are arteries, red vessels are veins. We've got to make that switch, right? In the pulmonary circuit, blue vessels are arteries and red vessels are veins of some sort. Once you get down into the alveolus, we're now talking about simple squamous epithelium. You also have simple squamous epithelium lining the capillaries, all the capillaries of your body. Right? Remember, all of your blood vessels have an endothelial layer, which is simple squamous in nature. So what I just described about the alveolus is here. These are very small little grape-like sacs, if you will. And it's here that there's gas exchange. Let's take a look at this a little bit more detailed view. And we're taking a look inside a single alveolus. There would be openings for air to come into this little area, and we see that all around it, right? 1, 2, 3, 4, 5, 6, at least, if not more, we see a series of capillaries. Those capillaries are carrying red blood cells. So when air comes into the alveolus, it only has to travel a short distance to jump a ride on the hemoglobin inside the red blood cells, and CO2 only has to jump a short distance out from the blood and from the red blood cells into the alveolus. Inside your alveolus, there are some macrophages. These macrophages, you can write this down, but they're sometimes called dust cells. Dust cells. I used to think that maybe there was a Dr. Dust after whom these cells were named. No. These dust cells, they're doing exactly what you think they're doing. These are phagocytic cells that are chewing up particulates, much of which is dust, that reaches all the way down into your alveoli. So if your cilia and the mucus of your nasal pharynx and down through your bronchial tree, clearly there will be some particulates that make it all the way down into the alveoli. And so if there are dust particles, pollen, whatever, that gets down into the alveoli, there are macrophages down here. So this is now, I believe, your fourth macrophage that you've specifically named this semester. You have dust cells here. In the skin, they were the Langerhans cells. In the bone, they were osteoclasts. And in the brain, we saw microglia. Those are all separate types of macrophages. Remember, all macrophages come from monocytes, one of the 5 white blood cell types. So again, looking for another connection, the monocytes made in the bone marrow, right? Some of them develop into these dust cells found in the respiratory system alveoli. Now, up earlier, I referred to the pseudostratified columnar epithelium as the respiratory epithelium, not to be confused with the respiratory membrane. So down here in the alveoli, we refer to the respiratory membrane. What is that all about? Let's think about this for a second. If air is in the alveolus, what does it have to pass through to jump a ride on the red blood cell. Remember, the alveolus is lined by simple squamous, and the capillary is lined by simple squamous. So the respiratory membrane is really a double layer of simple squamous with a little tiny bit of basement membrane that holds it together. So the respiratory membrane is a double layer of simple squamous, and that's the membrane or the layers through which oxygen and CO2 have to pass. If we look at the histology here, what we're looking at is lung tissue. You saw this long ago in lab 2, and one of the views you saw was of lung tissue. You saw the alveolus. So each of these little air sacs is an alveolus, and if you zoomed in, you would see a single layer of squamous cells. So simple squamous epithelium lining the alveoli, and that's where the gas exchange occurs. And then as you cut through a section of the lung, you can see that there are spaces present where there would be ducts, right, through which some sort of bronchiole or alveolar duct that brings air down into all of these microscopic alveoli. In your 2 lungs, if you were to count all the alveoli, it's estimated 300 million or so little air sacs. And if you could unwrap each of those little tiny alveoli and lay them down, the total surface area in your 2 lungs would be equivalent to a doubles tennis court. So if you were to imagine your lungs, right, which are easily contained within your thoracic cavity, but if you were to unwrap your 2 lungs and lay them out flat on a tennis court, right, it would fill up the entire thing. Pretty impressive for that amount of surface area dedicated to gas exchange. The majority of the cells in the alveoli are just called type 1 cells. These are the simple squamous epithelium. No fancy name, they're just type 1 cells. Then I already mentioned there's the alveolar macrophages. These are the phagocytic immune cells that are removing dust, and again, they're sometimes referred to as dust cells. And then there are also one other type of cell down here. These are called type 2 cells. Type 2 cells secrete a substance called surfactant. Now, surfactant is basically like a detergent. It's like a phospholipid protein stuff. And this is a substance which keeps your lungs from collapsing on each other. And this surfactant is not made by these type 2 cells until about the 32nd week of development. So when there is a preemie, when a baby is born early, if the baby is born after 32 weeks, which is still 2 months early, typically the lungs are developed enough that the baby can breathe on his or her own. However, if a baby is born before the 32nd or so week, oftentimes their lungs have not yet begun to create this surfactant. Those kids are going to have a lot of time in the NICU, in the neonatal ICU. They're going to spend some time working to develop their lungs, and oftentimes they will literally squirt a liquid, sort of like a spray, down into their lungs to put that surfactant-like material down in their lungs to help them breathe on their own. Again, that double layer of the simple squamous of the alveoli and the endothelium of the capillary is referred to as the respiratory membrane. So definitely take a look at these videos. They'll help you process and visualize all that I'm discussing here. Now, what can go wrong? All of us, I'm sure, have heard of asthma. Asthma is a relatively common condition affecting lots and lots of people. And really what it is, it's a chronic inflammatory response of the airways, especially of the bronchioles. Okay, so this is a condition of the bronchioles, not of the bronchi. Remember, the bronchi have cartilage around them, and so the cartilage is going to keep the airways open. Asthma is a problem in the bronchioles. They don't have cartilage, and so the smooth muscle of the bronchioles can get inflamed, and there can be mucus building up in there, and that is what leads to the airway issues. Looking at this diagram, you can see how much more narrow the lumen of the bronchiole is. And again, don't see any cartilage, right? This is the bronchiole, and it's that mucus buildup and that constriction of the airway that makes asthma so difficult. When individuals have asthma, sometimes they'll take mucolytics. Mucolytics, we know what this means. It lyses, it breaks down mucus, right? Breaks down mucus. So they'll inhale some mucolytics, and that is used to basically cut through some of that. And we can also take inhalers. Now, inhalers, or taken through a sprit inhaler, or through a nebulizer, a machine that pushes those medications into the lungs, especially of kids. Some of these inhaler molecules are basically a localized epinephrine, right? Now you know what epinephrine does to the lungs. You know that in a sympathetic surge that the airways open up. The respiratory rate goes up, but also the airway actually opens up. It causes the smooth muscles to relax. So when a person is having an asthma issue and they take a hit on their inhaler, that substance is basically a localized sympathetic, a localized epinephrine. You can think of it that way. And it bypasses them having to take a systemic medication, which would also cause their heart rate to go up and everything else. So that brings us to the end of 22.1. Make sure you do answer all the questions, including the vocab at the end, and label up on these activities. And let's now head on over to 22.2 on the lungs. So let's take a look at the gross anatomy of the lungs. Again, if you were to take all of those epithelial surface of the lung and spread them out, man, it's a huge amount of surface area. And the lung, you've seen this in the lab. You know that the right side is composed of 3 lobes. You can see those here. You have the fissures. Remember, from the nervous system, a fissure is a very deep groove. So we have 2 fissures on the right side and the left side. If we could see it, we would only see 1 fissure separating. The left side has the cardiac notch. That is the indentation for the lungs. We can see that here a little bit more clearly. So let's just review a couple things. We have the trachea. The dividing piece of cartilage here is called the carina, where the trachea splits into the primary or main bronchi. Okay, 1 bronchus, 2 bronchi, left and right. Secondary bronchi, lobar bronchi, and then each tertiary bronchus goes into a segment of the lung. And I'll just pause here and say for a moment that this is one of the cool things about the lung, unlike other organs. If a particular small section of the lung is diseased, it's possible, cancer or some other kind of trauma, it's possible to take that little segment of the lung out. And when you take that segment of the lung out, the rest of the lung is left intact. And so really cool, right, that we can take out these segments of the lung through disease or some sort of trauma, and the rest of the lung is able to work normally and completely. So again, you can see the cardiac notch here, and then the inferior, middle, and superior lobes of the right side versus the superior and inferior lobes of the left side. Blood supply. There is the pulmonary artery. You know about this from the cardiovascular unit. There's the pulmonary trunk that splits into the right and left pulmonary arteries. Those pulmonary arteries split down into pulmonary arterioles and eventually go down and deliver blue blood to the blood capillaries around the alveoli. In addition, however, there is also, let's go back, and then leaving, there's also the pulmonary arteries. in addition to the pulmonary arteries, there are the pulmonary veins and venules that carry blood back to the heart. Now, in addition, that's where I was going, in addition to the pulmonary arteries, there is also bronchial arteries. Okay? Bronchial arteries are the actual oxygen delivering arteries that bring oxygen to the tissues of the lung. So the pulmonary arteries are all about delivering gases for your entire body, right? The bronchial arteries are bringing the oxygen to the actual lung tissue. Okay? And these bronchial arteries are branches off your systemic circulation, meaning your lungs are receiving both a pulmonary circulation for gas exchange and a systemic circulation from the left side of the heart. Remember, the right side of the heart is sending blood over at much less pressure. That's the pulmonary circuit. But the left side is sending blood with much greater force. So there are the bronchial arteries that bring that oxygenated blood to the tissues of the lung, and likewise bronchial veins that return that blood back. There is a fair amount of nervous innervation going to the lungs. You're not surprised by that. You know from our discussion of the autonomic nervous system that the parasympathetic nervous system causes bronchoconstriction, whereas sympathetic would cause bronchodilation. Makes sense. When you are nervous, your airways are going to open up, allowing more air to reach the lungs. When you're relaxed, your bronchial tree will not be as large. It'll more bronchoconstrict. The nerves that travel to the lungs collectively are simply referred to as the pulmonary plexus. Recall, a plexus is a group of nerves, and they are going to enter into the hilum of the lung. Each lung has a hilum, a left and right indented region, essentially where everything enters or leaves. You know from lab 1 that there is the pleura around the lungs, and this pleura is made up of 2 layers. The visceral layer, shrink wrapped to the surface or to the superficial layer of the lungs, and it's going to extend and shrink wrapped all the way down into those fissures. And then there's the parietal pleura, that is lining the thoracic wall. Keep in mind, it's also going to be covering the superior border of the diaphragm. And in between those 2 layers, there's the pleural cavity filled with some serous fluid. And that fluid is helping to lubricate and minimize friction as the lungs expand. That pleural cavity is also the space where the lungs are able to expand. Covering the lungs in between the ribs are the intercostal muscles. Man, that makes sense, right? Intercostal, between the ribs, there are muscles. Those muscles are involved with the apparatus of breathing, with the expansion and the constriction of the thoracic cavity. And another way of thinking about the pleura is it helps to basically shrink wrap or vacuum seal. Let's use the word vacuum seal. The lungs are vacuum sealed to the walls of the thoracic cavity. So when you breathe, just take a breath, right? When you take a breath, look down, your chest is expanding. Your thoracic cavity is expanding. As the musculature of your thoracic cavity expands, your ribs, right, are a little bit flexible because of the cartilage, and your entire rib cage expands, your thoracic cavity expands, and your lungs are pulled open with that expansion. As your lungs are pulled open, it creates a larger volume, and air from the atmosphere is being pushed down into the lungs. Then when you breathe out, right, what's happening is that the thoracic cavity is squeezing down, pushing down on the lung, and air is being forced out. Now, what happens, however, if there's a puncture? What if there is a break in between the muscles and the rib cage and the actual lung? And if there is a puncture, that's called a pneumothorax. A pneumothorax basically causes the lung to collapse. So if a person has some sort of trauma, and sometimes a lung will simply collapse, what we call idiopathic, without any real known reason. Um, but other times people will have a collapsed lung and they go to the ER, right? They're having trouble breathing, and they go to the ER, and it's discovered upon imaging that they actually have a lung cancer, and that lung cancer has destroyed that pleural integrity, and sometimes that collapsed lung is the early sign of cancer and is actually a gift, because that cancer is caught earlier than it would be otherwise. So again, read about that pleura, and that pleura, here is that pneumothorax, the collapsed lung. And it's also possible for fluid to build up in that pleural cavity, and that condition is called pleurisy, and that simply makes it more difficult for the lungs to expand. Smoking can lead to emphysema and COPD. You'll learn a lot more about these conditions next semester. However, the irritants that come into the alveoli over time destroy the alveoli. And you might think, let me go back up to that picture. You might think for a second, going back up into the first section. Let me go down to the air sac histology. And speaking of emphysema, what emphysema does is it destroys the alveoli. And you might think, well, what's the big deal if I have little tiny air sacs, like we see all these little tiny air sacs? What if instead I just have a bunch of big air sacs, sort of like this, or here? Well, somewhere back in middle school, you learned that the collective surface area of a bunch of small spheres is far greater than the collective surface area of fewer larger spheres. So when a person has emphysema and the individual alveoli are destroyed, you're actually reducing the surface area for gas exchange. With that reduction in surface area, it becomes more and more difficult for the person to get adequate air in with each and every breath. So emphysema is a destruction of the alveoli and leads to a difficulty with getting enough air into the lungs. And also lung cancer is a high risk to those who smoke, and that is a relatively common form of cancer in our country. Thankfully, though, with the reduction in cigarette smoking and smoking in general, the incidence of lung cancer is decreasing, although certainly has not been completely minimized in our society. Make sure that you answer the questions here to part 2, and we are not going on to 22.3 through the end of this chapter.